other centers, sometimes after unsuccessful surgery. Okay, so I will present now some cases. This is an old case. You see that a male 35 years old, no risk factors, wife 36, submitted to partial operectomy due to endometriosis cyst in 2008. The patient was esospermic, FSH was high, testosterone level normal. Previous urologist performed also tubular markers which resulted negative. We are talking about 2013, and so he remained azoospermic, normal genetic examination, testis sonography with normal testis volume, relevant bilateral testiculopathy with many microcalcification and hypercoagulation areas. And the patient was submitted previously to testicular fine needle aspiration made in a University Center of Excellence in Italy. And they found on the right testis 8 mature spermatids, and on the left testis only circular cells. And they preserved, but at the end they considered that it was impossible to perform. And so they suggested this. The patient arrived to my consultation in 13, as you can see, and my microthese was performed on the right side. Intraoperative finding mainly very subtle tubules, a few isolated with a subnormal caliber, very few tubuli with a normal caliber, amidst a malassic parenchymal area which was biopsied for histology. Biological finding, a good number of sperm available, and all of these sperm were cryopreserved according to our habits at that time. This is an intraoperative finding. At that time I had not the possibility of taking photo immediately during surgery, and so this is a photo from my cellular, okay? And I remained surprised because there was this area with no clear borders, but with a strange curves, okay, and a strange appearance. And so clearly I took a biopsy. Well, histopathology, medium severe fibrosis, fibrosis, thickening of the basal membrane of the seminiferal tubules with not classifiable intratubular germ cell enucleation, intratubular calcification. Okay. And so the patient was called at the end of January 2014. A control ultrasound revealed irregular parenchyma, so 1 month later, in a nodular form at the same time, but we thought, at the beginning we thought that this could be the result of the previous microthese, okay. But at the same time, a small ductal area was found also in the left testicle, which had not been operated on. And so the patient was underwent a bilateral testicular exploration in an oncology university center, because at that time I had retired from São Paulo hospital, and so I had no possibility of operating on him in a public institute of oncology. And intraoperatively, 2 nodules were found. A biopsy was performed for fluid section examination, and the diagnosis was bilateral seminoma. The patient was submitted to bilateral orchidectomy. Some fragments were taken from the healthy testicular tissue from which spermatozoa were extracted and transported to my previous location of work, that is in São Paulo, okay? From the Institute of Tumore of Milan to the São Paulo hospital, okay, and cryopreserved. The patient remained in oncological follow-up, and testosterone replacement therapy was started. Well, 1 year later, thanks to the persistent negative oncological test, the woman underwent ICSI with a cryopreserved sperm obtained from the orchiectomy, okay, and however 2 ICSI cycle failed. For the third ICSI cycle, I thought of using the crescent sperm from microthese performed in Procrea as the first operation, and the pregnancy was achieved and the feeble baby was born. 2 years later, the lady, who was 30-year-old at the time, asked to try again with ICSI, and again the sperm from microthese were used. After 3 failed ICSI cycles, the woman was convinced by Massa to try again with the 4th cycle, and she got pregnant, and the baby was born in January 2018. So this is the photo of 3 years ago, okay? And my comments. Testicular fine needle aspiration failed to diagnose a carcinoma in situ, which then evolved into seminoma. This represents a very severe error from both medical and legal point of view. No patients should be monitored for the risk of testicular cancer until at least 45 years of age by monthly self-examination, ultrasound once a year, or in case of new suspicious finding. The rates of evolutive pregnancy with sperm from NOA patients are lower for a single cycle of ICSI, probably even lower when using frozen thawed sperm, and therefore the woman should be psychologically supported during her whole ICSI group, because several cycles are often necessary to achieve success. This is my comment at the time. Okay. And too long a period of time between retrieval and freezing in potentially suboptimal condition when I transferred the sperm retrieved from the Instituto of Tumori to São Paulo Bank of Semen could reduce the sperm fertilizing capacity. Okay. This is another case. Well, sorry, but I can't see exactly. Okay. This is now the next 4 cases refer to the latest years. Okay? And during this period, I decided to perform microthese directly and exactly in the same day of the pickup of the OSAT. Okay, so we use as a first we use directly fresh semen. Okay, so clinical history. This was an azoospermic man, 55-year-old. When he was 17-year-old, he had a follicular torsion on the right side with the testis atrophy, and 15 years ago, he was diagnosed of azoospermia, submitted to TESE at the time, but in another center with inadequate sperm finding. We don't know exactly which means inadequate. 12 years ago, diagnosis of hypogonadism, treated with tamoxifen, HCG, and Tosrex in the latest 4 years. Glucophage taken every day. Previously, he was a heavy smoker. Now with IQOS, or the electronic cigarettes. Okay. Woman is 42 years old, low ovarian reserve. You can see the intrafollicular count and the MAH. And previously treated by stem cell injection into ovaries, okay, in another center. He performed a normal genetic examination, testis sonography, right testis was atrophic, left testis very, very small, 5 milliliter patient, azoospermic, no germ cell. Tosrex was discontinued, and I prescribed the ACG, 2,000 units twice a week. He had no libido, huge tiredness, again a new semen examination, azoospermia, with no germ cell after centrifugation. I prescribed the clomid, okay, and Testavan together. He was informed of child health risk due to his age. This is an important advice, okay, when you face with an old male azoospermia. And he reported a normal libido and direction thanks to the endocrine therapy. And so in January of the last year, microthese was confirmed. Microthese was performed in the same day of ICSI, the intraoperative finding, notwithstanding our extensive and thorough exploration by means of 3 incisions, one on the caudal pole of the testis. Everywhere the testis parenchyma result made of only fibrotic tissue without any shadow of tubule, except for only 2 tiny areas, about 0.4 or 0.3 millimeter in diameter, presenting few tubules of fine caliber, which are picked. For macrolegioma are found. Biological handling of microretrievals, you see some sperm. Testis histology is made not clearly giving to the pathologist the best tubules, but retrieving a piece of the testis which represent at the maximum level the entire situation of the testis. Okay. Fibrosis and tubular hyalinosis. ICSI with fresh sperm, no oocytes metaphase 2, so we represent the sperm. Pick up no oocytes, no response to the stimulation, no response. The couple is evaluating oocyte donation. Okay. Well, this is the image, intraoperative image. You see fibrotic, this is the incision on the left, completely fibrosed. Here is the finding of few tubuli. Here. The only area with some tubuli. This is a caliber I used to measure the diameter of the tubuli during operation. And you can see I made some incision. One incision is here, and the other on the pole. This is the situation, and again at 36 magnification, this is the area where we were successful in finding sperm. Histopathology, tubuli with hyalinosis and tubules with polycerts. Comment: even an over 50-year-old man with hypogonadism in testosterone replacement therapy for many years may be prepared for a successful microthese by means of inadequate and enough long 1 year gonadotropin therapy. So 1 year of gonadotropin therapy. Well, this is the third case. This is a man, 52 years old. His second wife, 35-year-old. He had a bilateral post-parotitis orchitis when he was an adolescent. In 2004, he resulted cryptospermic. In 2005, Tefna worked with the ICSI in another center, pregnancy with a female newborn from his first wife. Then he began a new searching for a child, so he resulted as a spermic. FSH, you can see, was
the laser will not work on this.
The FSH was very high. You can see the testosterone. No, officially is good officially, but I consider for the age of the patient is good. Okay, I prefer when I treat non-static azoospermia to have testosterone higher than 3.5. Okay. In any case, it was okay, normal at that time. Azoospermia, again, the testisonography, 2 testes with a low volume, bilateral microdithiosis. The couple arrived at my consultation in September 21, and I suggest a macrothese after a preoperative treatment. In 22, you can say PSA because the patient is older than 50 years, okay? And the 17 hydroxyprogesterone is normal, FSH high, clearly, testosterone good, okay. In any case, I treated him with clomid. Then I tried to increase further the testosterone. You can see that again clomid was repeated, but when he was prepared for a microthese, the patient was worried for the programmed microsurgery and disappeared and consulted another center. There he was submitted to testicular fine needle aspiration, 6 needle aspiration from each testis, which with negative retrieval. And so 1 month later he came back to my attention. You can imagine that I was really happy. Okay, okay. So FSH again very high, testosterone slightly decreased, testis sonography confirmed, okay, in homogeneous testis echo pattern with bilateral microrithiasis. I treated him again with a clomid, and then I discontinued the clomid, and I passed to HCG twice a week, and at the end, in April 23, microthese was confirmed. And okay, the intraoperative finding on both sides of the parenchyma resulted made of hyalinotic lobulus with abundant fibrotic tissue and areas probably due to small hematomas. Seminiferous tubes are actually undetectable everywhere, except for few intact ones at the lower pole of each testis, where probably they were not able to perform needle aspiration. Biological handling on micro-retrieval is poor but positive. Testis histology rare, involuted and hyalinized seminiferous tubes with Leydig cell proliferation. ICSI was performed with fresh sperm, 7 on science and in metaphase 2, 4 fertilized, 2 blastocysts cryopreserved, 6 vials of cryopreserved sperm remain. ICSI was performed with thawed sperm, okay, because you can see that we obtained 2 blastocysts which were cryopreserved, but more blastocysts were needed because both couple members are phenylketonuria mutation carriers, and therefore blastocysts have to be submitted to PGTM. Okay, so at the moment the situation is in standby for this genetic examination. You can see the intraoperative finds. You can see that the testis is as a no tube. You can see full tissue completely abnormal. Okay, the parenchyma. Okay, you can see these are probably the result of a previous hematoma, I suppose, due to testicular fine needle aspiration. Again, you can see. And here you can see a small island of normal tubuli here at the 36 power examination, and so we retrieved the sperm from this island. Okay. My comments on this case: very high FSH and very low testis volume don't exclude a positive sperm retrieval. TEFNA resulted positive when the patient was cryptozoospermic many years earlier. But even multiple TEFNA resulted negative when he was azoospermic recently. Although the patient has had a past parotidic orchitis when adolescent, the severe parenchymal damage of the testis can probably be attributed to the previous numerous fine needle aspirations. This is the fourth case. Okay, the male is 45-year-old, wife 46. He was a bodybuilder and took testosterone for more than 10 years. And in September 20, testosterone was discontinued. You can see that the testosterone was very, very, very low. FSH was high, and his endocrinologist in another center prescribed to him Tostrex for 1 month. FSH remained high, clearly, testosterone in any case low. He was azoospermic. He was submitted to fine needle aspiration with no cell retrieval. In October 21, testis sonography showed two small testes, normal epididymis, left subclinical varicocele, PSA was normal, testosterone resulted incredibly high, and FSH normal. And when the patient arrived to my consultation in March 22, he declared to have discontinued testosterone therapy 5 months earlier. But I suspected that he was going on using medication without declaring it. And so I performed again hormonal examination. Again, testosterone resulted normal, and the genetic examination were normal, and the gonadotropins low. In fact, he was prescribed to suspend any hormonal therapy. And meanwhile, his wife underwent a huge ovarian cyst removal. Some months later, okay, you can see again FSH is high, testosterone is in any case low, and only in August 22 reported that he had been using DEA for a long time and discontinued only 2 months earlier. Parallel to the post-surgical period of rest prescribed to his wife, the patient was preoperatively treated for 6 months with ACG twice a week. Low libido was reported, okay. FSH again high, testosterone remained low, okay. I prescribed together ACG and HMG, okay. And during the ACG and HMG, the testosterone in any case remained low, always a low libido, incomplete erection, and I added the tadalafil. Well, my cortese was performed in February 23. Intraoperative finding on both sides, the parenchyma results almost fully made of fibrotic tissue. The tubular structure is substantially lost, except for small areas of subtle tubes devoid of germ cells in the right testis, and a few small subalbuginous areas with normal-sized tubes in the left testis. Biological handling of microarterial, sporadic sperm, extremely rare sperm, testis histology, tubular hyalinosis on the right side for 80% of the tubus and the SCOS for 20%. On the left side, tubular hyalinosis practically everywhere with only 2% of the tubus SCOS. Okay. We obtained only rare sperm and we used them in fresh ICSI. My comment is that if we had cryopreserved this sperm, probably we had obtained material not usable after thawing. Okay, and you can see 20 oocytes, metaphase 2, 14 fertilized, 4 blastocysts cryopreserved, 2 biosol cryopreserved sperm, first blastocyst transfer pregnancy, and in December 2023, a male baby born. Okay, and at the time, HMG and ACG are continued, but we will stop clearly and substitute with testosterone replacement therapy. Comment: even a previous androgen therapy prolonged for many years, causing such a robust inhibition of endogenous testosterone production to make it apparently unresponsive to gonadotropin therapy, might not be an absolute contraindication to microbiome. You can see here the testis incision. You can see that practically all the parenchyma is completely destroyed and substituted by fibrotic tissue. So, okay, again, and you can see that this small area, very tiny. Yes, it was like the sphere of a European, okay, with a normal tubus where you could find the story. Okay, you can see again there, and this is the histopathology. Okay, so last case is a patient with this clinical history, testosterone constantly low for years. normal libido and erection, genetic exams normal. When he more than 10 years earlier, FSH was extremely high, LH the same, testosterone level very low, and azoospermia with no germ cells. He was prescribed the Nevid by another endocrinologist at that time, and Nevid was continued until February 2016. Then he discontinued it spontaneously. Again, FSH very high and testosterone in any case very low, but with a normal sexual activity. In February 21, the patient, at that moment he was 31 years old, comes at my consultation. His wife is young, and FSH again very high, free testosterone just above the minimum normal level, 17 hydroxyprogesterone normal. Okay. He was prescribed HCG twice a week for 6 months. Okay, and again 3 times a week, again for a lot of months, as you can see. And the day after, in a HCG 5,000 unit injection, testosterone was only 1.36. 4 days later, testosterone again clearly was decreased and plummeted. However, during the 6 months treatment with HCG, 17 hydroxyprogesterone results always within normal values, and therefore mycothese was programmed. So mycothese was performed in December 21, intraoperative finding on the right testis, lightly reproductive parenchyma, mainly made of subtle tubes, in depth a few areas with lightly subnormal or normal tubes, mainly adjacent to lipic cell groups and tiny arterial vessels, biological handling or micro-retrievals, rare spermatozoa, partly used and partly frozen, testis histology tubes with complete spermatogenetic arrest, and ionized tubules with Leydig cell proliferation, X with fresh sperm, 13 oocytes, 2 fertilized, 0 blastocysts. So ICSI was performed again with a thawed sperm, and from 11 oocytes, 5 resulted fertilized, 2 blastocysts, 1 transferred failure, 1 was frozen. Okay. And HCG treatment was continued in waiting for a second transfer of the blastocyst, but again a failure. And in February 2023, the patient asked to undergo a second mycothese. This is a histologic examination. You can see tubes with a thickened basal membrane in the red arrow, and ialinosis, Leydig cell hyperplasia, green arrow, okay, on the left side, and the spermatogonia, red arrow, and spermatocyte, black arrow, and the circular cell, green arrow here at a higher magnification on the left, on the right. And so we in February performed the second mycothese, intraoperative finding, and in this case we had the donor sperm available clearly. Okay. Intraoperative finding on the left testis, like in the right testis, fibrotic parenchyma mainly made of subtle tubes with a few areas with a slightly subnormal or normal tubes. The biological handling of microretrieval, very rare spermatozoa, to sperm bias were frozen. Testis histology to random microbiopsy, 90% of tubular ialinosis and 10% scroll tubus. ICSI was performed with fresh sperm, 13 oocytes, 9 fertilized, 4 blastocysts preserved, transfer of the first blastocyst, pregnancy with a female baby born on February of this year, and 3 blastocysts remain preserved. Okay. And so this is the intraoperative testis image pre-these. You can see 2 centimeter the longer axis. Okay, this is the baby, our lady here with the baby. The baby is the front of the patient, not the patient. Okay. and you can see here some intraperitoneal image with the tubules. Okay, this is a good tubules. Okay, and we remove the vent. Okay, and you can see again other two tubules. Okay, and this is the histology, histopathology, tubular adenomyosis, and pseudonodular Leydig cell hyperplasia. Comment, a very severe hypergonadism with a very high FSH, very low testosterone lasting for many years, and unresponsive to HCG treatment cannot be an actual contraindication to microthesa. Serum 17 hydroxyprogesterone may be a useful indicator of the intratesticular testosterone. The case report was published, you can see recently. Okay. But at the time, we had only the blastocyst, not the newborn was had to arrive. Okay, and so my take-home message is: apart from the few cases where the guidelines recommend to desist from surgical sperm retrieval attempts, that is AZ and AZ complete deletion, there are no cases, even with an extremely poor prognosis, where a microthesa cannot be successfully attempted. Here, the superiority of microthesa versus thesa results are really indisputable. Okay, this is about the long controversy about it is better microthesa or thesa, no thesa is the same as a microthesa. This is completely out of discussion, because it is evident that all the cases I have presented today, if were submitted to thesa, would result negative. Okay. If you have a long experience in microthesa and you have biologists with excellent expertise in this field, you should feel a moral duty to try to help the NOAA infertile couples solve their existential problem. Therefore, after an appropriate and truthful information and having signed a written consent, never give up. Thank you.
Thank you very much, Professor Corti, for this excellent presentation. And now, do you have any questions?
I would take the opportunity. Congratulations, because it's a really excellent presentation how you have done it, and showing these highly extreme cases which have been able to find vital sperms. Comment for case 452 or the first one. So indeed, I'm recommending the same as like you, always do a histology, and sending always a lab, always. Never do it alone. I think that's out of the guidelines, should not be done. Secondly, in the case 452, the second one, I was wondering why the patient was submitted before on Tostran, and then, even less,
What the patient was
on Tostran, Tostrex yes. Was the name, and then before the microthesa, you stimulated it under Testavan. So you added exogenous testosterone and
yes.
You stimulated.
So
that was wondering a little bit from me.
Yeah, you are right to be surprised, because officially it seems strange, and was strange also for me.
Yeah.
The problem is that in that case I asked information. I asked for information an endocrinologist. Okay, and Florence. Professor Maggi,
yeah.
to say his name, and I asked them, please, I have this patient, okay, and if I treat him only with ACG or clomid, etc., I am not able to increase his testosterone level, and he told me, well, try to keep also the testosterone therapy. So this is not my own choice, because I am not so expert in endocrinology, okay, and so I followed his suggestion. This is all.
Now that's highly interesting, because the quintessence is that we agree that we need a high testosterone concentration, at least one threshold, knowing that what you measure in the venous is not the same as the testicles. So to have an environment is highly important. So we agree at that one. And secondly, we came it out here. There are cases where you cannot stimulate to get the normal testosterone production by adequate access from the testicle. Some of here are not so over the picture, 2-3 millimeters or in false cases. And I can say recently I had the same cases, but I was not successful, honestly. So I had to find a hyalinized testicle without any sperm. So there's a well done study. So well done. So my comments. My respect.
You know that there is a very low evidence that increasing testosterone level can increase the sperm retrieval and successful.
Yeah.
Okay. But in any case, I follow this indication, okay, and every time I prefer to prepare the patient for some months, trying to increase his testosterone level, okay. And in the last cases presented, it was completely impossible. It is a strange case because. His testosterone was always low, always low, and even the free testosterone was very low,
Exactly.
And notwithstanding this, the patient had the normal libido and the normal sexual intercourses, okay, and
but you know
and no sign of
But the
hypogonadism.
reason might be that he has another receptor for testosterone, so
Yes.
the CPAP control the
And
genes
so
for
we
that
decided to use the 17 hydroxyprogesterone as a marker of the intratesticular testosterone. This is
That's excellent. Thanks a lot.
okay.
I want to comment in a complimentary way the lecture from actually the case presentation from Professor Giovanni. I must say that this for many of our young audience should show that the field of andrology really has a lot of possibilities.
Yes.
And this is a lecture which tells you in a very evidence-based manner the results of each of the different case of surgical procedure that was done for inpatients, along with the data from the embryology clinic, which is where Giovanni is working. So you can see how he has followed up on each and every patient which he demonstrated, what their findings were. They were sometimes unsuccessful, and then because the field is highly advanced, you need a lot of knowledge, lot of experience to treat these men. So yes, it is difficult, and that is why this type of master class is really very important for you to build your knowledge base. It is important to understand that if you don't have the knowledge, then you will not be successful, and you will say that okay, this patient can not become pregnant, because you don't understand how to really investigate and manage that patient. So I believe the master class that is being organized by Professor Giorgio here is an important landmark for this country, because such course has never been held in all of Morocco or in many other parts of Africa. So this gives us really the hope that many of you will really try to learn more about andrology and not give up. And if you have doubts, you have all these experts that you have met, you can write to them, you can consult with them and take their help. So this is really one of the messages that I want to convey, that this is the pure example of evidence-based medicine. Here he is not saying that I was able to get the sperm, but then what happens, because that is 99% of the people who are doing these procedures, they don't have any follow-up data. And getting the follow-up data is like connecting the dots to tell what really happened after that. And a lot of work is done in the lab by the biologists. So if you don't have highly qualified biologists, very motivated, because each procedure takes hours and hours of time for them to really find the sperm that have been dissected from the tissue and preserved, cryopreserved. So if the people in the lab are not highly motivated, they are not very much cooperative, then lot of hard work that andrologist has done is going to go to waste. And that is why a very good team is important for the success of microtesting. Without a good team, one person cannot do everything. So it is a team approach which is really the hallmark of a microtesting success. Without that, I think most of the urologists that I meet and I hear in conferences, they're only singing their own praise, that they did this, they found this, that. But then, you know, for others who are really looking at the outcome, there is nothing for them, because that once the sperm go to the IVF center never share the results. They are all like bundled up in so many procedures. So tracking the things when the sperm are preserved to the actual use, and this is long term, as you saw, some became pregnant after a year or 2 years. So this is a really important thing to say, that the procedure that I did, the way that I retrieved the sperm in completely azoospermic cases, and they resulted in healthy babies. So many cases you saw, and I think this take-home message is very pertinent. It really tells that you have to be truthful, and you can. I think almost everybody, except for one or two conditions as he listed, for genetic condition, you can basically cannot say that the baby, you cannot have a baby. That is just I think a incorrect information to tell. Don't you think?
Sure. I must thank you for your comments, because this is the most important message. Okay, you know how long I pressed the Global Androgyny Forum about azoospermia to invite all the members, okay, to try to be helped really by their biologists, because we need the biologists experience in the biology. And